I'd like to start the second part of our program now. We have our fourth prize winner, who will give a talk now. Dr. Luis Augusto Horde is with us. I took a long time practicing that name. Coming from Brazil. He is a professor of psychiatry and the chief of the Child and Adolescent Psychiatry division at the Federal University of Rio Grande do Sul in Brazil. I think it's longer from Brazil here than from Norway here, but we can talk about that over drinks at dinner. We're glad to have two such illustrious worldwide winners of our prizes. He's best known for his focus in child psychiatry and ADHD. In addition, he's a prolific educator, influencer, and a physician around the globe. He has 65 trainees listed in his CV, but I'm sure that's really not all of them. He has 417 publications with an H-index of 57. He's been called one of the most highly influential psychiatrists in the world. I don't know exactly the measurement parameters for that, but we can talk about that. He himself has said how it is to build a research center in a developing country, making it part of the international research map in child and adolescent psychiatry. Dr. Unda.
Thank you very much for this nice introduction. Thanks to BBRF for the award. And I have a very difficult challenge here today, is how can I put a story of 30 years of research in 15 minutes? So I tried to do it in a small 5 chapters. The first one is addressing an issue that we took sometimes for us several years ago. Is there a difference in ADHD prevalence rates between Europe and North America? The second one, is ADHD always a child-onset, a neurodevelopmental disorder? 3, is it possible to predict ADHD young adults based on childhood data? Third, is behavior inhibition the central ADHD neuropsychological mechanism? And can we do research on ADHD with immediate translation to national policies? So let's go to our first chapter. 20 years ago, there was a huge discussion about the differences on the prevalence rate of ADHD between North America and in Europe. And there is an idea at that time that the difference is mainly determined by cultural issues. So at that time, we conducted a meta-analysis and a meta-regression. Nowadays, every undergraduate student can conduct a meta-analysis and a meta-regression. But at that time, there was only 11 meta-regressions, several meta-analyses, but only 11 meta-regressions in medicine. And we did it with 102 studies from all around the world in all continents, for assessing the prevalence of ADHD in children and adolescents, and we found the prevalence around 5.3%, but the most important issue in this paper is that when we adjusted for methodological issues among the papers, how the investigators conduct the study, the difference in the prevalence rate on ADHD completely disappeared. So it was very important to put ADHD as a biological disorder and not something influential, extremely influential by the environment. For this reason, there are in the PubMed, in the Web of Science, by the way, the citations is from the Web of Science on the number of the influential. There is 80,000 papers on ADHD in the Web of Science, and this is the 8th most cited paper on ADHD. So the second issue, we always understood ADHD as a childhood disorder, a neurodevelopmental disorder. What is essential for a neurodevelopmental disorder? In the criteria is that it begins in infancy or childhood, the first manifestations of the disorder. Since 2000, with samples in Brazil, we found that there are a group of children, adolescents, and young adults that have the complete phenotype of ADHD, but do not have the age of onset in childhood. We published later a review of our studies showing that there are no significant differences in people beginning the phenotype after or before infancy. Then Terry Muffet, another one prize winner some years ago, invited me to analyze with their group the data from the Canadian cohort in New Zealand, and she took all the adults with the ADHD phenotype that are 34 years of age, and then, as this is a birth cohort, we assessed also the symptoms in childhood, and she was able to document that in a populational sample, 90% of the adults at 34 years of age, they do not have a clinical diagnosis of ADHD in childhood. And we did, and this is what we did published in JAMA Psychiatry, a paper where we assessed exactly the same research question in a Brazilian population in adults 22 years of age with an ADHD phenotype, and we found exactly the same finding. A lot of these people with the ADHD phenotype in young adulthood did not have a clear diagnosis. What is important here? That to conduct this study, we took advantage of the birth cohorts in Brazil. We have in Pelotas, a small city in Brazil, birth cohorts. Professor Cesar Victor is following everyone that was born in 4 different years, 82, 93, 2004, and 2005. 2004 and 2015. And we have data for the 4,000 in each cohort, all phenotypic data, and we are including ADHD, and we are able to document exactly the same. So it's important in a research center to work cooperatively when you are below equator with the people that really do research in excellence in different areas to have an impact. So what is the message of this in terms of trajectory? We all know that the trajectory of ADHD, that people with a very low vulnerability have a low expression of ADHD symptoms. People with a high genetic vulnerability express highly the phenotype. There are a group that have a high vulnerability, express high, but because of maturation of prefrontal cortex, they decrease the symptoms. This is the 3 trajectories traditionally known on ADHD. What we documented is that there is another trajectory that are people with moderate symptoms of ADHD during childhood that when they are put in the huge demand in the transition from childhood to adulthood, they begin to express much more symptoms. Who are them? There are people with ADHD with high IQs, mild symptoms, and probably raised in families where someone in the family worked as a prefrontal cortex, accessory prefrontal cortex helping them. And when they need to get a more autonomous life, they explode the symptoms. So, how about prediction, personalized medicine in ADHD? We all know that there are risk models in medicine, and one of the most traditional is the Framingham risk model for cardiovascular disorders, where if you put some variables like age, blood pressure, cholesterol, and several others, you can predict the chance of mortality for cardiovascular disorder in 10 years. But we have very few models in mental health and in psychiatry. So what about if we can, for instance, predict if this young boy, very hyperactive, will continue to be an inattentive young adult, or this very focused girl, if she will develop a late onset ADHD. So to do this, we made a collaborative work with 4 different centers. The MTA is the hugest clinical study on ADHD in the United States, the 2 bird cohorts in England, and our bird cohort in Pelotas. And based on data using machine learning and other sophisticated mathematical modeling, we are able to construct a risk calculator that is freely available for everyone, that enters some variables from childhood. You can predict the risk of persistence of ADHD. What is the clinical relevance of this? One of the most important questions that parents ask you when you are assessing child with ADHD is, my son, my daughter, always will have ADHD? This is not a deterministic predictive model, but at least give some science in the way of giving the response. And there is this review that assessed 100 models in psychiatry and put that this model that we developed is one of the 2 with the lowest risk of bias, considering the way that it was created. So when you talk about neurobiological mechanisms of ADHD, the central aspect when you talk about the neurobiological mechanism is behavior inhibition. The people put a lot of emphasis on behavior inhibition as the core feature in terms of problems of executive function and the problem that will derive other problems in executive function. Giovanni, that is seated here, published with us several years ago a study that documented that the story is not exactly like this, that behavior inhibition is important, but there is something called drift rate that is a measure, a more basic neurocognitive processing, that when you take this in consideration, part of the explanation of the neurobiological underpinnings of ADHD are connected to these more basic processing problems. And 1 month ago, Daniel Pine, who is the chair of the committee for the RUN prize, published that if we want to really reduce the ADHD phenotype, we need to go to this more mechanistic neurobiological underpinnings or problems that you see in the disorders, and using this drift rate as something that might be important to try to decrease the heterogeneity in the phenotype of ADHD. Why I'm bringing this study? Because its study was only possible because we created in Brazil one of the best in low-middle income countries populational neuroscience cohorts. We selected from 10,000 children at 10 years of age from São Paulo and from Porto Alegre, my city, 2,500 kids, 1,500 at high risk for mental disorder, 1,000 randomly selected, and we have been following them since 10 years of age. Now they are in between 20 and 30 years of age, and we are following now their sons and daughters, and also their parents. This is the first transgenerational cohort in a low-middle income country, and we have everything about the phenotype, DNA, and neuroimaging, MRI of them. So with this kind of design that we create, we have more than 150 papers published on developmental psychopathology, not only on ADHD, but we have the opportunity to study different aspects of child-adolescent mental health. And finally, in my last chapter with you, is can we do research on ADHD with immediate translation to national policies? In São Paulo, that is a city with 21 million inhabitants, we have, believe or not, 250 moto boys, the motorcycle delivery guys in the city. And we have each day 10 deaths of these motorcycle delivery boys in the city. we decided to assess the prevalence of ADHD in these motorcycle delivery boys, and do they have more problems in terms of traffic accidents, fines, and those that have ADHD, and we clearly documented they have a much higher prevalence of ADHD, much higher problems with traffic accidents. Based on this, there was a bill in our Congress that make a mandatory assessment, a clinical assessment for ADHD when we are taking the driver license for conducting motorcycles, and they are thinking of expanding this for driving as well. One of the most important accommodations when you have ADHD is the extended time. You receive an extended time during exams in fundamental, high school, and in entrance exams for university. But there are very few science behind the decisions. Should someone be given 25% extended time, 50% extended time? This is an area where the policy comes before the science. So we conducted, this is very fresh data, we are just finalizing the analysis, we conducted a very sophisticated analysis with 120 people with ADHD and people without ADHD at the university or doing preparation course for the university, and we put them in a random distribution of 3 tests, one with the normal time, one with 25% extended time, one with 50% extended time, the group with ADHD and the group without ADHD. And as you can see here, the group with ADHD in blue, this is the baseline, the performance increase with extended time, and the performance of the people without ADHD did not increase with the extended time. So we are assessing the predictors, and we are putting science in the policy for accommodation that is a policy used worldwide. So with this, I'd like to thank some of my mentors, Professora Maria Lucrecia Zavascki, who put a lot of stimulus on studying childless and mental health since I was 16 years old. It was my first year in the medical school. And Professor Maria Inês Schmitz for the part on scientific approach. Professor Joe Biederman that put me in the ADHD business. I never spent more than 3 months out of my hometown, but the 3 months that I spent with Joe. And my colleagues that work with me all along my life, Professor Maria Helena Rutz. I didn't have time to show you our studies on molecular genetics of ADHD, but we do a lot of molecular genetics, and Professor Euripides Miguel, who constructed with me the Institute of Developmental Psychiatry and the cohort, the Brazilian high-risk cohort that now is coordinated by Professor Giovanni. But also to our hospital that 1 month ago was considered the best public hospital in Latin America in terms of clinical and research, and mainly to my students. I have not 65, but almost 100 master degree, doctor degree, and postdoc worked with me. And during this presentation, I selected among them 4 that you see the figures how. Why I selected? Because this prize, my understanding is that it comes to us because for 2 reasons. The first one is because we are able to construct a research center below equator in the global south that is as good as any other in developed countries, and this is something very difficult worldwide in this environment. And the second one, because we put a lot of effort in investing in young investigators. These guys that I selected here nowadays are doing and are leading research on child-adolescent mental health, not only in Latin America, but here in New York and in other parts in different areas of child-adolescent mental health, not only ADHD. I want to finish just telling a story to see that the vision is very aligned with the vision of BBRF. In my university, I don't know in yours, but the full professors do not like to teach for undergraduate students. My strategy 30 years ago was I decided I will teach in the second semester, third semester of the medical school in the very early beginning. So these guys like Giovanni that sit here, I was able to recruit him for mental health before the people from cardiology or endocrinology get them. So, and invest and nurture these brain and minds to make the difference for children, adolescents, and old life. Thank you very much.
We have time for questions. There we go, right there.
Thank you so much. I love long-term longitudinal data. So my question is, ADHD, you started with these kids when they were 10 years old, and it's often a prodromal illness. So my question is, since you have all this data, have you been able to look and see the people that have been given treatment with stimulants versus just treatment with behavioral therapies, and follow them through and look at the incidence of psychotic illnesses developing over time?
That's a very, very important question. But remember that we are talking about low middle-income countries, and whenever we are following people in cohorts, the majority of them, differently from the United States, do not have treatment. But we did a very nice study that we assessed in the Pelotas bird cohort, the guys at 11 years of age, 4,000 children with clinical and scales information from teachers, and we selected 300 that clearly have the phenotype for ADHD at 11 years of age. We reassessed them at 18, 19 years of age, and 65% of them without, because this is not no intervention from our side, just 20 of them had medication from the 300. 65% of these 300 did not have, at 18 years of age, enough symptoms or impairment to qualify for a categorical diagnosis of ADHD. This is probably not what happened in clinical samples, where you see people with more severe disorders, more comorbidity, more complex cases. But at least in the populational level, you see a lot of maturation and a lot of strategies developed that can compensate the symptoms and impairment.
Sometimes I've heard questions from people wondering if a little bit of ADHD is important and it makes you more productive. I'm sure the answer is no.
I think that part of the answer was given by my colleague before, showing the relation between the cognitive development and bipolar disorder. So I think that there are, certainly, I think that there are, when you go to the press or the media, we have a lot of romantic presentation of ADHD, and we need to be very clear that ADHD is a disorder with a clear impact for people. But at the same time, I think that we should look for positive aspects that people living with this disorder might have. I give you an example. One of the studies that we did is assessing the relation of ADHD and entrepreneurship. And we found entrepreneurship. We found that the capacity of some of them with a certain level of impulsivity, they are able to take risk more than the general people, and this might make a difference when you are trying to begin a new business or so. There are some issues that we need, and even in terms of creativity, there are some studies showing that people with ADHD might have a level of creativity higher in general than other people. So I think that there are some positive aspects that we need to pay attention.
One more question. Well, of course.
With a large longitudinal study like you had, 10,000 young people, as they matured, did you see the prevalence of any other disorders that were associated with the people who had ADHD?
Yes, we are discussing exactly this point yesterday here at the Child Mind Institute, that yes, as far as we are following the people, is impressive the amount of other disorders, in a way that if you look, for instance, in the birth cohort from Terry Muffet in New Zealand, at 40 years of age, she was able to document that around 80% of the people have a mental disorder. In our populational cohort, we have data just for people between 20 and 30 years of age. And at this time, we are already seeing a rate of disorders like this one. It's impressive that one disorder in childhood might make and increase the risk for new disorders later on. So this is the importance of taking in care about developmental psychopathology. We need to understand the risk factors better and really improve the ways of intervening in these risk factors.
Thank you very much. Appreciate it.
Thank you very much.